Thank you very much, Prof. Now, instead of Dr. Hala, Dr. Paulo again will speak regarding LADA, a well-known form of autoimmune diabetes without a therapeutic algorithm. Until he opens his slides,
yes.
I really enjoyed the physiology or the pathophysiology of diabetes. We have to read more about this. We have to understand the disease more. Please start, Professor Paul.
Thank you. I think this presentation came very well after Prof. Defonso, because when I, the famous octet, I was thinking about what's going on and how things are changing. And indeed, one aspect that is very relevant for type 2 diabetes and LADA is the inflammatory area around the islets. And then I'm talking about that, how that could be explained, some of the form of autoimmune diabetes in adults. Now, I'm going to talk about autoimmune diabetes in adults and some new therapeutic approaches for that. Now, in this review by Raffaella Buzzetti on the interaction of beta cell function, autoimmunity, and insulin sensitivity, you can see the three major players in what is autoimmune diabetes in adults. Called LADA, called MIRAD, but there are different names, 1.5, whatever. But the key point here is that the beta cell function, insulin sensitivity that are crucial to type 2 diabetes are here accompanied by autoimmunity. How autoimmunity play a role together with the beta cell function and insulin sensitivity. So autoimmunity is a relevant issue because it's typical of type 1 diabetes. And many people say that type 1 and type 2 diabetes are within the same sort of disease, but with different expression, different pathophysiology. But LADA is a very perfect mix of the two. What is LADA? By definition, and I'm not going to talk about that, but it just say adult age onset of diabetes greater than 30 years, presence of autoantibodies, lack of insulin at diagnosis for at least 6 months. If you get into insulin treatment before 6 months, it's not LADA, it's type 1 diabetes in adults. Keep in mind that these are the current definition of LADA. What is the epidemiology of LADA? If you look at the frequency of autoantibody positivity in many studies done over the years, even in the Middle East, in the United Arab Emirates, the paper by Ernesto Maddaloni screened 17,000 patients, and you see the percentage of positivity for antibodies is very low compared to the other part of the world. But it's around 5 and 10% of all cases of diabetes. So it's a reasonable number, because if you think that type 1 diabetes is 10% of all cases of diabetes, and LADA is another 10%, LADA equals type 1 diabetes. So we have to pay attention to LADA. And there are no guidelines for LADA. Soon there will be some guidelines suggested for LADA. Now, finally, after 25 years since the first identification of LADA done by Twomey and Paul Zimet in a paper published in Diabetes, 1993. That was the first time when LADA was presented. But actually, Umberto Di Mario and James Irving, before I talk about type 2 diabetes and autoantibodies in 1983. So this is what's happened about LADA. So as you see here, the percentage of positivity. And when you talk about antibodies, what are the antibodies in LADA? Well, 4 antibodies, easy to remember. GAD antibodies, tyrosine antibodies, IA2, zinc T8 antibodies, and tyrosine phosphatase antibodies. These are the 4 antibodies that are fine. And check the last one, the tyrosine phosphatase 256766 is a different form of tyrosine phosphatase antibodies that is relevant for what Ralph mentioned before, and I'll show you some data about it. Now, positivity in type 2 diabetes patients compared to LADA. As you can see here, these are the data of patients with GAD antibodies and IA2, GAD antibodies and IA2 and zinc T8, GAD, IA2, zinc T8, and IA2, including that sequence of the 25676. And as you can see, the percentage of patients with these antibodies in a population of type 2 diabetic patients that were not known to be LADA. So that is a considerable number of patients, suggesting that indeed, if you want to be good in defining the type of treatment for these patients, you need to measure GAD antibodies in all type 2 diabetic patients, because you will find some LADA. In particular, in some phenotypically defined patients with type 2 diabetes, and I'll show you where you should measure LADA. Now, regarding GAD antibodies, we have two different GAD antibodies, high titer and low titer antibodies. And as you can see, this population defined, as I will show you in the next slide, two different populations. The low GADA are very mild autoimmune patients compared to the high GADA titer, defining different phenotypes. And then when you look at the frequency of other specific autoantibodies in LADA, according to the GADA titer, what you can find in the dark blue are the high GADA titer. Look how many TPO, tyrosine peroxidase antibodies, are present in that population compared to the others. Even 21 hydroxylase antibodies, thyroglobulin antibodies, and parietal cell autoantibodies are definitely more frequent in patients that have high titer GAD antibodies. So the high titer classically define a patient that is an autoimmune patient. If you have low GAD titer, even the other antibodies are at low levels or maybe negative. So definitely these are two different populations within the classical autoimmune patients with type 1 diabetes, with autoimmune diabetes. That is confirmed with the BMI. That is really a key point. Look at the quartile distribution of BMI in LADA and type 2 diabetes. Less than 26, you have the LADA in pale blue here, and the type 2 in dark blue, and look what is the percentage of positivity. When you go into BMI of 26, 28, if you go to the BMI 28, 32, and when you go to the BMI of greater than 32, clearly suggesting that the BMI is related to LADA. So autoimmune diabetes in adults or LADA positive patients are leaner than the classical type 2 diabetics. So the first message that came out of this study, well, if you have a patient with type 2 diabetes that is even manageable well, but with a BMI between 25 and 28 and 30, think about potential LADA. You may say, what is this, an academic exercise? Measuring GAD antibodies in these patients maybe are well controlled with drug? No, it's not. Because their evolution over time will become to insulin. Because the beta cell function in these patients tend to decline and they will become insulin treated. So it's not an academic exercise to measure GAD antibodies in that population. Now here there are some clinical characteristics of LADA and NIRA, that is the other expression, non-insulin requiring autoimmune diabetes, and type 2 diabetes according to the number of antibodies. Now you have 3 antibodies on top, 2 antibodies, 1 antibodies, and none. Look what about the age at diagnosis, 43, 45, 52, 51. What about HbA1c? Look about BMI, 24 up to 29. Look about the waist circumference, from 84 to 98. Fasting glucose, triglyceride, total cholesterol, and the other antibodies. And even the typical O3, O2, O1, HLA genetic susceptibility, you can see that are highly significant comparing the type 2 diabetic patients and those with antibodies. So I think this is a clear demonstration that LADA is a different form of diabetes to type 2 diabetes, to classical type 2 diabetes, and also to type 1, because the large majority of these patients do not need insulin. They are autoimmune, some beta cell dysfunction, but they don't need insulin to start their disease. They will become eventually type 1 classically in terms of insulin treatment, but it will take around 5 to 10 years, depending on how other factors may play a role in the progression. This is what I mentioned, the different combination of GAD antibodies with IA2, the different IA2, and as you can see, there are differences in body weight in some of the BMI and waist circumference and fasting between different GAD with or without the sequence of the IA2 antibodies. But I think this is going into too much details. I don't want to discuss that for the purpose of this presentation. What is of interest is the C-peptide concentration. Now, the C-peptide concentration of type 1 LADA and type 2. By definition, in type 1, the C-peptide is below 0.2 nanomolar. If you have 0.2 greater, fine. According to the DCCT, you have less complication. That's fine. So good patients with type 1 have some residual beta cell function. Look about the LADA, type 1 and type 2. LADA is in between the type 1 and the type 2 diabetic patients. So even the beta cell function is there to start with and tend to decline. Usually the majority of patients with LADA are diagnosed with a C-peptide around 0.6, 0.7, up to 1 nanogram ml, that is talking about 0.3, 0.4, 0.5 nanomolar. So they still have residual beta cell function. So here is where the sort of comparison between a moderate type 1 genetic susceptibility on top and the type 2 genetic susceptibility take to impaired insulin secretion. From the left-hand side, you have a normal overweight obese, specific trigger, allele autoimmunity, beta cell apoptosis, insulin deficiency. On the other side, you have the obese patient with low-grade inflammation. These antibodies are typically associated with obesity, that is an IA2 tyrosine phosphatase antibody with the 2, 5, 6, 7, 60 sequence, accelerated loss of beta cell function, and impaired insulin secretion. This is where the Raf, when he mentioned about inflammation, is definitely that characteristic of patients with type 2 genetic susceptibility and a modest inflammation that is driven by presence of autoimmunity. Now, I'm going to say something about targets of ideal treatment in LADA. Obviously, you have to obtain a good metabolic control and to protect the function of the muscle beta cells. How? Treatment options. Diagnosis, diet, price, exercise. If you look at what is available for treatment option, we have insulin, sector-gold, insulin sensitizer, GLP-1, DPP-4, and now SGLT2. Effect on beta cells, replacement stimulus in different glucose-dependent stimulus, and what are the results of the study? I think that this study published 10 years ago on JCM really, and then confirmed by other studies, definitely defined that patients treated with sulfonylurea and LADA can actually be promoted towards insulin therapy. As you can see here, these are the patients after 60 months of follow-up, free from insulin, insulin group treated with a small amount of insulin and looking at C-peptide, and those treated with sulfonylurea, suggesting that sulfonylurea definitely should not be given to patients with GADA positivity. And this is the variation of C-peptide treated with insulin or sulfonylurea. As you can see, you tend to lose C-peptide. So forget about glibenclamide or other drugs that stimulate beta cell function. This is the also a follow-up of 7 years, the paper published by Simona Zampetti and Raffaella Buzzetti. You look at the proportion of patients free of insulin therapy, and as you can see, the patients treated with metformin or TZDs. So even here, a large proportion was a combination with TZDs. And this is the first study clearly demonstrating that TZDs in LADA may be very good because you can protect beta cell function compared to sulfonylurea and insulin sensitizer, comparing to insulin sensitizer. And sulfonylurea where you speed up the destruction of beta cells. What about GLP-1 in LADA? Now, conceptually, the GLP-1 may be an excellent compound for LADA because they increase beta cell proliferation in vitro in animal models, increase beta cell hypertrophy, reduce beta cell apoptosis, and favor beta cell neogenesis. So then the GLP-1 may be used in this condition. Now, both GLP-1 and I can show you and the DPP-4 in that respect. Now, these are the data about sitagliptin versus insulin. As you can see on top, there is sitagliptin plus insulin versus insulin alone on fasting plasma glucose in 2 hours C-peptide. The two in the middle are the C-peptide. And as you can see, that clearly the sitagliptin plus insulin works better than insulin alone in protecting the decline of beta cell function in patients with LADA. So that is a demonstration that that works. This was with sitagliptin. Linagliptin, so it's a class effect. Linagliptin again on beta cell function at baseline, and after 104 weeks, so this is a really long-term study, you find that the C-peptide is better preserved in patients that were treated with linagliptin. Now, SAXA. This is our study published a couple of years, 3 years ago. Again, the GADA positive versus the GADA negative on fasting C-peptide on the postprandial C-peptide area under the curve. Saxagliptin works well in patients with LADA. So that could be a combination of Saxa, it's either Saxa, let's say no combination, either Saxa, Lina, and Sita, all three have similar effect, so that definitely is a class effect rather than one of these drugs. And then finally, the dulaglutide is the long-acting GLP-1 that has been tested in this study that we published last year. And as you can see here is the mean change of HbA1c. This is just on glucose control and HbA1c in patients with LADA compared to, there was a post-hoc analysis of the award 2, 4, and 5. As you know, the award trials were the trial using dulaglutide in different patients populations with type 2 diabetes. And dulaglutide works even well in patients with high GABA titer, so also in those patients that have a strong predisposition to autoimmunity. So I'm going to conclude by saying that LADA is an autoimmune disease. However, LADA includes an extremely heterogeneous population. The titer and the pattern of autoantibodies highlight the presence of different genetic autoimmune and clinical phenotype of LADA. Guidelines are not available at present for LADA. However, drugs that preserve beta cell function are recommended, and those which speed up destruction should be avoided. Thank you very much.
I was told that you are leaving.
No. This discussion, question.
You will wait for another lecture.
No, I have to go to another lecture.
Yes.
So,
If that's why I'm holding you.
yes, right.
Before
Okay.
we leave this session, is there any question specific for Prof? Please. Please. You after that.
Okay.
2 questions, not more.
First of all, thank you, Doctor. First of all, I would like to thank you, Doctor, for such a great lecture. My question is, we've mentioned that there's a period of time where we're actually going to need insulin in LADA, which is 5 to 10 years.
Yes.
So my question, what would you think is a first line? I know there's no guidelines right now, but what would you think is good for first line treatment? Because you mentioned it's very good, it's that sitagliptin and insulin, they're very good, but why give insulin when it's mentioned?
Well, the aim, and just to clarify this point, thank you very much, the aim is to protect beta cells, to avoid beta cell loss, because the DCCT clearly told us that you have your C-peptide in type 1. If you have a C-peptide that is preserved, you have less complications. So this is the first goal of your treatment. Of course, this first goal is a long-term goal. To get that first goal, you need, of course, to control metabolic derangement. And there, I suggest that clearly sulfonylurea are out, metformin is out, DPP-4 and GLP-1 are the 2 drugs, and TZDs are the 3 drugs, including TZDs, the 3 drugs of choice in LADA.
Can I ask another question?
No.
You mentioned treatment of LADA, but you skipped the answer about SGL2 inhibitors. Why you did not mention it?
I did not mention a GLP-2 inhibitor because data trials are ongoing at the moment. There are no trials showing, I presented evidence base, what we have for LADA. There are trials ongoing. If you do on ClinicalGov, you can find the trials with SGLT2. Data probably will be available next year.
And is proven about these trials till now, or?
No, there are no data. There have been few abstracts, but no data about the safety of SGLT2. Of course, there is great expectation about the use of SGLT2 in LADA because it works in type 1. So if it works so well in type 1, it may work in LADA. It is also an autoimmune disease.
I would like to thank you very much, Prof. Sorry for delaying you. Have a nice trip. Thank you.